So we will be live streaming there, and I'll share the live stream link on Twitter. No pressure if you don't feel like retweeting it. So we will be, I will switch the view to speaker as well. So wonderful. We are starting to have people trickle into the YouTube. Great.
And I'll retweet you if you'd either tag me or is it on your personal?
I'm typing as slowly as I can. Okay, wonderful. Well, we will just go ahead and get started. Thank you, everyone who's tuning in today or tuning in at a later date to enjoy a conversation, cultural heritage role and health sovereignty. This presentation and panel discussion is made possible thanks to the wonderful 1772 Foundation. And we're just really grateful to be here to have conversations on the role the past has on the present, and look forward to having that with you all. So we're going to start by having quick introductions from all of our panelists, and then we'll move on to more of a Q&A conversation where any of you can just chime in the comments either on YouTube or on the Dismantle Preservation Discord channel. If you have a question that you don't feel comfortable going public, you can also DM me on Twitter, and I'm happy to share that with our panelists as well. We're going to do this in alphabetical order, so that means Gillian Frank is first.
Hey, everyone. Thank you so much for organizing this, Sarah. It's a real pleasure to be here. My name is Gillian Frank. I am a historian of religion and sexuality. This year, I am an affiliate fellow at Princeton University's Center for the Study of Culture, Society, and Religion. Basically, my work operates at the intersections of the histories of religion, sexuality, and race in the United States. Some of my publications have included Editing Devotions and Desires, which is an anthology or an edited volume that explores the histories of religion and sexuality in the US. And also, we had a recent publication in American Jewish History looking at the histories of sexuality and Judaism. You can find some of my public-facing work in Slate, Jezebel, Time, The Washington Post, among other places. But most of my public history work is in a podcast called Sexing History, which explores how the history of sexuality shapes our present. We are about to publish our 4th season this fall, and you can find us at www.sexinghistory.com or wherever you get your podcasts, you can stream us.
Wonderful. Tegan?
Hi, everyone. My name is Tegan Kehoe. I use she, her, hers pronouns. Thank you so much, Sarah and Dismantle Preservation, for having me. I am a public historian, and I specialize in museums and in the history of healthcare and science more broadly. I am also a new parent, so I have a 3-month-old. So if I space out in the middle of a sentence today, I apologize in advance. If that doesn't happen, please forget that I apologized in advance. But I'm happy to be here for this conversation today. I work at the Russell Museum at Massachusetts General Hospital in Boston, which is a museum of medical history and innovation. I am also on the board of Digital Commonwealth, which is a Massachusetts-based online repository for historical materials from institutions throughout the state. And my current claim to fame is that my first book recently came out. That's Exploring American Healthcare Through 50 Historic Treasures, published by American Association for State and Local History Press, which is a co-publisher of Rowman and Littlefield. That is part of a series that looks at various topics in American history through the lens of museum artifacts and historic sites throughout the country. So my book looks at late 18th century through today, 50 different artifacts and historic sites from around the country, looking at different elements in healthcare and medicine.
And is it true, Tegan, that if someone looks at your website, they might find a coupon code for that book?
That is true. That is available on my website, and I try to make it so that if you can spell my name, you can get in touch with me. So my website is tegankehoe.com, and that's also my Twitter handle and other ways to get in touch with me.
Wonderful. Kamal?
Hello, everyone. Thank you, Sarah, the 1772 Foundation and Dismantle Preservation for organizing such a wonderful panel. My name is Kamal Patterson. I'm a cultural heritage attorney in Maryland and Washington, D.C. I look at all aspects of cultural heritage, whether it be intangible, tangible, built heritage. I just love exploring the dimensions of the things that we cherish. I'm also the lead at Artiv for a project for photogrammetry in Syria. And I'm also an ambassador for Artiv, which is an art loss registry and database. And so one of my most recent projects, and I'm really proud of, is I'll be a contributor to the 1526 project, which is a consortium of scholars that have come together to look at the foundings of the republics in the Americas and the various contributions of Black and Indigenous peoples to the founding of those republics. And I'm also going to be a professor at the University of Maryland in the Historic Preservation Department in 2023. And I'm so excited to be here. Thank you again.
So excited to have all of you here with us today. I am going to share my screen because plot twist, I don't just do dismantle preservation work, I actually sometimes research. So hopefully the share screen is working for everyone. Is it? Thumbs up from my fellow presenters. Okay, so basically, I started last year to explore the history of my great-great-grandma, which is Bess Prather. She also frequently is known by her husband's name, which is Charles Prather. So growing up, I would always hear these stories about Bess and how Bess worked with Margaret Sanger. And I think you might be like me, and sometimes family includes stories of hyperbole. So I wanted to double check and fact check and see what was true or not. So I spent some of my extra time in the pandemic exploring my family's history, where in fact I did confirm she didn't just work with Margaret Sanger. My great-great-grandma Bess Prather actually was a part of the Birth Control Clinical Research Bureau for a number of years, lobbying for birth control clinics to be established in specifically Arizona, New Mexico, and Western Texas. The photo with Margaret Sanger from the previous slide was them in El Paso together. So in exploring this collection, which is held by Smith College, this is not a digitized collection, but you can email them and they will send you photos and scanned in items of the letters. I learned a lot about her work. You know, I must have some new tires, traveled 20,000 miles. And you can only imagine what the roads looked like in 1930s Arizona to travel across the Southwest to try and advocate and lobby. And these letters actually showed her work led to her divorce. Her husband was displeased of being known as Mr. Bess Prather, and he did not like her being a notable woman. She was the president of the Arizona Women's Federation. She ended up being the first postal master of Casa Grande, Arizona, but all of her work that she was thoroughly dedicated to led to also her dismissal. She had a teaching certificate, and she did not have any medical background. She was just a fierce advocate for equality and for women's access to health care, but that was not considered what the birth control movement needed at that time, and they shifted their standards in the late 1930s to require medical backgrounds to be advocates for clinics. So where were these clinics? I'm a trained preservationist. I want to know where these clinics ended up being established. And they were being established, and I'm tracing the exact locations based on these letters. You can see in this slide, one that was established in Phoenix. The letters would also say which cities had the most opposition. There's a lot of references to Catholic opposition in Santa Fe, New Mexico. So, okay, where were these locations, and are these stories being actively preserved? I'm going through historic markers, I'm going through national historic designations, I'm looking for any sorts of designations of original birth control clinics or the individuals associated with advocating for them. And based on my research thus far, the only actual designation tied to the history of women's access to birth control is Margaret Sanger's headquarters in New York City, the Clinical Research Bureau. And what's funny about that is the local designation from 1975 is based on the architecture. It's not based on what happened there. And then that was fixed in the National Historic Landmark designation in 1993 that remedied that. So, you know, we're continually re-exploring what our history is, but it also ties to our present day issues. According to the Planned Parenthood website today, there are only 4 Planned Parenthood clinics in New Mexico, 7 in Arizona, and 41 in Texas, which actually surprised me. So, you know, I want to look at where were these original clinics established? Are there still clinics in those communities today? And what does that say about our shifting demographics, our shifting community needs, and our shifting politics as a whole? And we're all here for dismantle preservation because, in the words of Bess, I believe you have to do more than march and shout. So we're going to dive into our conversation now and really just start to explore how health ties into this larger conversation. We'll start with medical history in the States is tied to power dynamics, wealth, gender, race, sexuality, mental health, etc. These are conversations that have been historically excluded from historic designations, not just Margaret Sanger's headquarters, but also let's look at the Kirkbride Hospital in Buffalo, New York. It's a National Historic Landmark and is colloquially called the Richardson Olmsted Complex, named after the architect of the building and the landscape architect. You can find the asylum easily on Wikipedia, but the text is almost exclusively limited to the architecture and landscape design. So I want to start us out with a question for the panelists. How do we move beyond design appreciation and toward telling a fuller narrative? And again, to our audience, as you have questions, throw them in the YouTube chat and the Discord, or you are also welcome to just DM me on Twitter if you don't feel comfortable with something being public. So who wants to kick us off? How do we move toward telling a fuller narrative that includes medical history?
I'm happy to start, but I don't want to step on toes if someone else was about to speak. All right.
Go for it.
Well, I think that there are a number of different factors that go into this history being ignored, even at the sites where it's extremely relevant. And certainly we could do a whole panel just on that. But I think that a couple of the factors are a lot of the very significant former hospitals, former sites of inpatient care that were considered asylums or institutions, clinics, and so on, that are either preserved or still standing, and there's material available publicly about them, are really being preserved by passionate volunteers. And they come, and many of the ones currently involved, their passion is on the side of the architecture or the design or a very reductive version of history. And so there are plenty of people who are passionate about justice, who are passionate about talking about the history of power dynamics and race, sexuality, gender. And I think that some of them know that there are very rich stories to be told as related to medicine, but the people who are passionate about it aren't necessarily the ones who are involved in the historic preservation of these sites. How do we fix that? That's another topic that could be an entire panel, but I think that more of this type of conversation, bringing people into the fold, bringing people who are involved, who came into it from the architecture or design side. But then also in my work in medical museums, I've noticed that quite a few of the medical museums, at least in the United States, are institutionally affiliated. They're affiliated with a parent organization that is a current either hospital or medical center or medical school. sometimes also nursing schools and other professional training. And many of them are hesitant to share the darker chapters of their past, possibly because people will point out that we're not that far away from them, either chronologically or ideologically. And so that lack of institutional independence is certainly, I think, a contributing factor. It's not always like that. There are definitely exceptions, you know, especially with famous institutions. Tuskegee has a nice kind of commemorative center working on sort of the stories of the Tuskegee syphilis study. But that one, they almost were obligated to do that because their name is so closely associated with that study, even though it was largely run by the US Public Health Service. And so institutions wanting to protect their own images, I think, is one of the other contributing factors. And I don't have an answer for that one, but I did want to point it out.
It's a great example, like the Kirkbride in Buffalo, they've been able to rebrand it essentially. So any other thoughts, Kamal or Gillian? Kamal, you're muted.
Sorry about that. I definitely agree with all of Tegan's points. And I think that one of the things that we can do is, you know, do exactly what you're doing, you know, researching your family history when you find out about these facts about relatives. And this dovetails perfectly with an article that I have been reading in the New Republic. It's called The Chilling Persistence of Eugenics. And the author is doing some family history and some research concerning a family connection to the Western State Hospital, rather lunatic asylum, as it was called, in Staunton, Virginia. That's the place where the famous Buck v. Bell eugenics case involving sterilization. That's the facility where these events took place. The young woman that was the victim in that case, her mother had been committed to the center in 1920 for feeble-mindedness and these kind of stereotypical diagnoses that were, you know, often based in class prejudice. And she herself was committed in 1924 after she was assaulted by her employer's nephew. And so, you know, when we look at the preservation of Western State Hospital, and we look at kind of the stories of people like Carrie Buck and all these, you know, people who suffered there, you know, the building itself architecturally is amazing. But there's a dark history there that even in official records for the Western State Hospital, which is now the Villages at Staunton, it was sold to private developers. They go out of their way to not really talk about the fact that you had people that were being held there basically on trumped up accusations of promiscuity, feeble-mindedness, all kind of manner of accusing people of being social degenerates, and that this having them committed was the only way to keep you know, society's bloodline from being tainted by people who were supposed to be perpetual criminals or descendants of undesirables. And so, you know, people doing research on family history, finding out about the people like Dr. Joseph DeHarnett, who was the superintendent of Western State Hospital. And he was very much connected with other eugenicists in Virginia, like Dr. Albert Priddy, and also Walter Plecker, who was over the Bureau of Statistics in vital statistics in Virginia. He did a lot of kind of racialization of statistics, you know, finding out about these individuals. And we'll see, like Tegan said, that we're not really that far, that these issues of race and class and gender and mistreating people, committing people for quote unquote being socially undesirable, those things are still going on. And, you know, we have places where those things took place, but we don't really, you know that because the public facing history of these sites have whitewashed those things.
I'll add on briefly, and I want to just extend appreciation to what my co-panelists have said so far. So right now, my current book project is on the history of liberal religion and abortion before Roe v. Wade. I'm currently writing about one of the first freestanding abortion clinics in the United States, which was built in New York City. And I have all the architectural designs, the ways in which it was envisioned, the sort of idealized version of it. And this is a very different story than how was the space used, who went there and why, who worked there, what was the nature of the labor, what sort of conflicts emerged around how time was spent in a building. And so I see there's two distinct histories. There's sort of one in which how a medical establishment gets licensed, how it gets built, how it gets constructed, the sort of flow of patients as it's imagined, right? But then when I speak, and I have interviewed some of the folks who worked there, who founded it, what do you remember about the space? How did it smell? What were your feelings about it? The sort of human histories and how they inhabit architecture are quite different. And so incorporating those voices, those experiences around a very basic question, which was who occupied a space? What did it mean to them? How did it change over time? Might be a good way of beginning to introduce these stories. And so I would offer that as a beginning.
I think it's a great point that it isn't to say design isn't valuable, right? Because the designs speak a lot into how we have chosen to give care. And the Architecture is Political podcast has had recent episodes with architects who are designing abortion clinics and what they have to consider for safety of individuals. And that sounds like a great book to research. So we'll make sure to stay tuned to your Twitter. So I think a lot of us have probably grappled with this issue, and Tegan alluded to one of the limitations that leads to this. Cultural heritage practitioners, in addition to members of the general public, believe that our work should be apolitical, that the stance seems to come, and this stance seems to come for fear, for institutions, fear of losing donors, or for the general public, maybe they have fear of having to confront things that they were taught. And just last week, a very well-known national history organization published a column condemning presentism. So what are ways you all have found to contextualize your research as a launching off point for activism or creating resources for the public? What have you found, and when you've gotten pushback, how do you push back to your pushback to use this expanded narrative for empowerment or activism or just basic educational purposes?
I'm happy to start on this one. So just to offer a little context to what Sarah was alluding to, the outgoing president of the AHA published a column on presentism. It was the subject of a lot of ire. An apology was since issued. It's also the subject of a lot of ire because it was deemed unsatisfactory. But the question was, what is the role of political concerns and present-day concerns in shaping historical pursuits? And so I'm trained in several fields that come out of political movements and out of searches for a usable past. I'm a women's historian, I'm an LGBTQ historian, I was trained by labor historians, and I do histories of race and ethnicity. And these fields were all born out of a simple fact that stories about the past are stories that we tell each other about ourselves. Which stories get told, which voices are included, whose voices are excluded, what gets remembered, what gets forgotten, what can be spoken about in public, and what must be silenced. These all reflect power relationships. These are all political choices. And so my fields take these as axiomatic. But I would push this even further and say, what gets considered apolitical and what doesn't get considered apolitical are themselves results of power relationships. So if we take this as our starting point and go to the question about resources, and I'm just going to speak to my podcast for a moment, which I co-host with Lauren Gutterman. We have a wonderful team, but what we do is we use tightly scripted narratives, we use oral histories, and we use archival sound as a way to invite listeners to think about and engage with the past. And our website, again, has transcripts, it has lesson plans, it has bibliographies, all of which act as resources. So one of the ways in which we think about this podcast as being responsive to politics, but also as offering a tool, is that we hope to create and teach a critical vocabulary for thinking about sexuality and its history. And we do so because we live in a time in which sexual politics is of profound national import, whether the issue is trans rights, whether the issue is abortion and birth control, whether it's about gay marriage, and the list can go on and on. Sexual politics shapes electoral outcomes and it shapes everyday lives. And so we hope to give our audience a means of thinking about the social forces that continue to shape our present and to do it in a way that's engaging and entertaining. So why a podcast? One of the things that we discovered early on when we started this was there were very few podcasts at the time doing histories of sexuality. But more than that, our field of research has largely been text-based. It's been the written word, or it's been a translation of AV mediums into the written word. And so there is this huge sonic archive that has been largely unexplored or unheard. And so we wanted to use that and also to use oral histories as a way of letting historical archives and archival sources speak for themselves, even as we interpreted them in a broader context. Now I'm putting an asterisk on speak for themselves because the moment you curate, nothing's speaking for themselves. But we wanted to allow these voices to be heard and to let them share stories. So depending on which of our episodes you hear or you choose, you might hear the voices of abortion providers and abortion seekers. You could hear activists from the anti-rape movement, sex workers who worked on phone sex lines, people with AIDS engaged in struggles for dignity and healthcare, gay and lesbian rights activists who are looking for means of dignifying themselves and struggling for equal rights, and so on and so forth. And so for us, the podcast is itself a resource, hearing those voices is a resource, but it also is a way of, and we make these moves deliberately in our scripted versions around this, to make the connections between past and present, to show the timeliness and the fierce urgency of the past.
I love that reminder that the work doesn't stop after an oral history is collected. It's how do we use it as a tool? And there's a billion ways to disseminate. Tegan and Kamal?
After you, Tegan.
Thank you. Well, I really appreciate what Gillian said, and I don't have a ton to add. I did wear my Museums Are Not Neutral t-shirt today intentionally. And for those of you who are unfamiliar, that is a campaign hashtag t-shirt movement that was founded by Latanya Autry and Mike Morosky, talking about the fact that it's not actually possible for an institution that's disseminating knowledge to be completely neutral, and pretending to be neutral isn't helping anyone. Everyone has biases, institutions have biases, and it's possible to be nonpartisan, but you can't be apolitical and talk about people's lives, because things that affect real people, power dynamics around sex, race, gender, disability, wealth, all of these things and many more, are part of the subjects we're talking about. And, you know, I study medical history. You cannot separate those things. You can gloss over those things. And that's what many people do. And so one of the things that I do, one of my kind of small contributions to using my research for justice and for activism is just to be very deliberate about not glossing over difficult matter, not glossing over discussing power imbalances, human rights violations. If someone makes a racist statement and I am describing their statements, say racist rather than controversial. And if someone says something that is advocating the view that society would be better off without some people who are burdens on others, I refer to that as eugenicist rather than edgy or something like that. And so just that level of honesty, it does bring my own biases. I have a bias towards human rights, and I own that. And there are plenty of other biases that I have just from my lived experience as a white person, as a queer person, as a woman. I have other biases as well, but recognizing that it's not possible to be unbiased, but it is possible to be honest is kind of what I try to bring to my work.
And you bring up such a good point of the way we soften history. My reading tied to the birth control clinics established, there's lots of references to Margaret Sanger's desires for population control, which we know she was a eugenicist. So how do we soften words, and how do we move past that to deliberately face history? It's a difficult one for all of us to shift those daily habits, but it's a daily habit that can be shifted for a more equitable and inclusive field. Kamal?
So just to kind of go off of your point, I think it's like in being intentional and deliberate and showing the nuance that exists, right? So you mentioned with, Sanger being a eugenicist, and there's a distinction. Got positive eugenics, which is marrying well, which is problematic and has ethical concerns, but that's distinct from negative eugenics, which is sterilization, which are what happened to so many poor women and women of color in places like the Western State Hospital. And so looking to see, talking about how society's values and visions for what makes a better society, the kind of nuanced levels to that, but then also just showing sometimes built heritage or built structures themselves are political, and kind of showing how nakedly political they are. Like when you look at, things that are dedicated to Confederate soldiers, the United Daughters of the Confederacy, they were very intentional in showing that we are doing this because we want to preserve the history of the Confederacy, but in a way that meant preserving the white supremacy as a political regime. And so, the United Daughters of the Confederacy built heritage in politics. There's uses of space that are political as well. When you look at the progressive era, when you see like psychologists, moral reformers, police, the groups of people who were disabled, people who were non-gender conforming, various people who were targeted because of their identity, people were okay and voted for officials who would use public space to oppress people, to categorize them and to other them. And these spaces in which they inherit, in order to kind of show, hey, this was political. They went after people who were sex workers, like under what was known as the American Plan, which was co-signed by even us, the ACLU back in the day, essentially was going after women who were suspected of carrying venereal diseases. And so they rounded up women without due process. Many were detained for years, some were able to fight back. But these were choices that people in society were saying, we need to isolate these people, they're bad for society, and we need to close spaces where these people congregate. And so going to archives, going to newspapers, getting testimonies from those who were detained or otherwise incarcerated in these spaces is really important to see that politics can be used as a cudgel against people, and politics can literally create space to oppress, and showing how that oppression played out and the stakeholders in society who were involved in that oppression is very important. But it's also important to the autonomy of those who suffered to get their stories and to incorporate them in an interpretive context, whether that's audio, whether that's text, whether you have people that are, if it's a living history type site, making sure that you have people who are using snippets of things that they said to portray, this is what happened there. I think that we have that level of integration where we respect what people went through. We understand the political and cultural forces that created that oppression. And then I feel like that's the best way to kind of recontextualize or properly contextualize built heritage that still exists in the medical or medical or social hygiene space.
Any bounce back thoughts from Tegan or Gillian?
Those were great points. I'm just going to affirm them.
Yeah, it's a lot of what we're talking about today is the very recent past. And the past few years have amplified how recent the trepidation to get vaccines because of this forced sterilization of people across the country. The fact that our monkeypox vaccine has been very much targeted toward gay men, and it's echoing the AIDS crisis. We can look at all of our states that have been successfully taking away access to birth control and abortion, and at the federal legislation level. So it's kind of hard to continue using that soft language, and it's hard to ignore the recent past. But I don't know where I'm getting at with this, but I think it's really tough to see how our health education, whether we're talking about, sex ed in schools, is under threat, or talking about history education, has fully omitted these difficult topics for whatever reason. So have any of you seen examples beyond your own work, or maybe additional examples of your work, where you're seeing great opportunities of connecting the past to present right now to, again, not just use it as an empowerment tool, but, I just feel like I've seen eugenics talked about so much more in the past year than I've ever have in the rest of my life. So what are some historical figures, objects, pieces of legislation, or places tied to history of health that connects to present day issues that you think everyone should know about, that should help people be advocates for themselves or their community, or something more broadly like that?
I'll be glad to start. And I want to show an image. I'm going to caution that it might be a little upsetting. It's all typed text, but here we go. So what we're looking at right now is what was called a negative list, and various abortion referral organizations would share this. This one comes from the Clergy Consultation Service on Abortion. The predecessor to NARAL had a similar one. And what you can see on this list is the name of doctors who would provide abortions. All of these were illegal abortion providers. This is a list where it's reviews of them to warn abortion seekers away. And so you can see under one of them, danger of infection, avoid; filthy, dirty, expensive, avoid; under surveillance, old, careless; not a licensed doctor, et cetera, et cetera. I'm going to stop the screen sharing for a moment. Now, why bring this up? This list is a byproduct of a moment, a very recent moment in American history, pre-Roe, where people were forced to travel for abortions. What word do we use for these people who were forced to travel? Conservatives right now want to call them abortion tourists. We can call them forced medical migrants. We can call them displaced because of restrictive abortion laws, but how we term their travels matters profoundly in how we narrate both past and present abortion seeking. This list is also an artifact as a result of medical scarcity, of the ways in which abortion was criminalized and stigmatized and shamed, and where people were forced, because they couldn't access legal abortion care, out of desperation, to go to illegal providers. So I think that when I show this image, when I show this list, this attempt by everyday people to help abortion seekers navigate a vast and unregulated abortion underground, I want to share it as a warning that this was in people's living memory and living experience. I've interviewed a number of abortion seekers who have had to go through that particular thing. We describe being blindfolded, picked up on a street corner, not knowing who was operating on them, and then having to go get medical triage as a result. I think these horror stories, not calculated to shock, but as we hear what's emerging out of medical scarcity states, low access, no access states now, 10-year-olds who are having to travel across state lines, people with ectopic pregnancies, people who have to get put in precarious health conditions. It's not a far cry from this list, from this scarcity that is forcing people to take desperate means. And so when I show a list like that, when I curate it in front of an audience, I think about how this past is all too present, how the warnings from it about what happens when there is state-sanctioned medical scarcity, criminalization, and shaming is a cascading effect of desperation and danger. And so I would begin with that artifact as a way of launching a conversation.
And if people want to explore that topic even more, there's a documentary on HBO called The Janes, about female activist underground network. And then there's going to be a fictional retelling called Call Jane with Sigourney Weaver and Elizabeth Banks, also exploring limited abortion access and the travel required for
Sure. Those are good places. Jane is a slightly different story.
Yes.
In that they were basically as a DIY seizing the means of reproduction, as they might have termed it at that time. These particular lists there come out of ARAL, Patricia McGinnis, Clergy Consultation Service on Abortion, and a number of feminist and abortion rights groups that basically said, we want to get you to licensed physicians. It's a slightly different history, but the distinction is worth pushing upon just for a moment. Whereas Jane believed that they could learn how to provide at least first trimester abortions, these referral lists were to help people from all stages of pregnancy. And the reason I say all stages is that first and second trimester would often slide into each other because of the delays in finding information, but to get them to competent physicians who would help them. For resources on where to find that, there was an episode of Criminal that features the Clergy Consultation Service. There was some, Lily Lithbrow had a fantastic article. I think it was on Jezebel, maybe it was on, I'm going to have to get the reference, on Patricia McGinnis and her work. And there's a lot of great scholarship talking about the abortion underground at that time.
Great. And one follow-up before Tegan and Kamal's. As your research has explored this underground network, are you finding it across the states, or are you finding it limited to major metropolitan areas? Let's kind of dispel myths about where the network existed.
Sure. So in my particular research on the Clergy Consultation Service on Abortion, they were active at various times in 40 states, at least 2 Canadian provinces. They had people traveling from probably all 50 states to access them, as well as international travelers. They had outposts in Tokyo, Japan, and they referred folks to 3 or 4 different continents for medical health care. So North America, Europe, I should say 3 continents, and parts of Asia, specifically Japan. And so this abortion referral network that was clergy-based was 40 states, but just about every state had some sort of referral service of one sort or another, whether they were commercial or not-for-profit, whether they were women's liberationists or just purely exploitative. Because there was a dearth of information and because there was such high demand, such medical scarcity, creating a map of this abortion underground to direct people where to go was just part of the texture, the horrible texture of everyday abortion seeking in life at that point.
And, you know, as a preservationist, I always want to tie things to locations. I assume it's near impossible to actually find where medical services were provided in this instance. It would just be maybe this neighborhood, or?
So it depends which story we're telling. And so we could tell it in a couple of different ways. And I don't want to speak for too long about it because I know Kamal and Tegan have wonderful things to add, but I will say this. We're right now for our podcast, we're just finishing up writing the script for the story of Curtis Boyd, who operated out of a small town in Texas called Athens, now very popular because of the show Cheer, but back then was a rural agrarian town. And we know exactly where his doctor's office was, which he opened the doors for thousands upon thousands of abortion seekers who came from across the Southwest. We know where a number of these clinicians were, where a number of these physicians were, became the home base because we have the documents that give the exact addresses and the coordinates for many of these providers within the network.
Wonderful. So in theory, we could preserve and make that more amplified. Kamal and Tegan, what object, piece of legislation, place, or historical figure do you think everyone needs to know from the history of health that connects to present day?
I would say, well, I have two really quick. So about the abortion, the abortion issue and the persecution and prosecution of abortion providers and connecting that to place, this makes me think of the story. I believe her name was Inez Burns. She was an elite. They called her the abortion queen, and she operated, I think, in San Francisco, and she had been pursued through various eras. She was also the subject of a target by, at that time, Governor Brown of California. So finding places where Miss Burns, operated out of, whether those were, the clandestine places or places that may have been known to women at the time through perhaps a referral network, would be an interesting subject to explore. If those places could be preserved in San Francisco. And then as it relates to, we talked a lot about maternal health and the abysmal maternal death rate for Black women. And a couple of years ago, there was a protest against a statue in New York City of what they consider the father of American gynecology, Marion Sims. And Dr. Sims performed many different surgical procedures, hysterectomies and such, on enslaved women without their consent and without anesthesia. So, as we look to places, we can connect that to the history of slavery in New York, and then also the history of health for vulnerable women, and connect that to the current debate that we are having about Black maternal health, which is a crisis in this country. So connecting that to maybe places where we can find, plantations, places where he visited to perform these surgeries on enslaved women, those sites should have that interpretive context, or could have that interpretive context added to it.
And I'd just like to give a shout out for the Georgia B. Williams Nursing Home, which is operated by midwife Beatrice Borders. It's in Georgia, and it is one of the oldest midwifery establishments in the entire country, operated by Black women, which is, the next phase of history beyond what you're saying. But it kind of ties into, once again, having to self-create safe spaces to access medical care. Tegan?
So I am also thinking about reproductive health because of current events. And one history that I think that we could all benefit from understanding better is the history of hormonal birth control and the pill. And it was, as many people know, a huge step forward for people who can get pregnant, mostly women, but it was also a step forward in the health and safety for many non-binary people, and trans men weren't necessarily being discussed in those terms at the time that the pill came out. But the more I have learned about this story, the more I realize how multifaceted it is. Because certainly it was, very important for people's health to be able to plan their pregnancies, decide when and how many. But then when you look at the stories, especially the testimony from people who started using the pill shortly after it came out, they were discussing being freed from being constantly pregnant, being freed from having 7 or 8 children, and barrier methods of contraception had been available. They had existed for quite some time, and they had been legally available for decades. And so the sort of the untold story here is the people impregnating them not having the same goals and not respecting the rights of the people getting pregnant. So typically, husbands deciding how many children to have, or just deciding they don't like condoms or whatever, and women's lives being wildly altered by the fact that their husband is the one choosing whether and how they have sex and when and how many children they have. And so there's stories of consent violation and stories of marital rape that often really aren't discussed in the history of birth control. But then also the development of the pill itself has fascinating histories, especially in the power imbalances between the people developing the pill, the people who the pill was tested on, and then the people who were able to access it. There's a great book called Jungle Laboratories, Mexican Peasants' National Projects in the Making of the Pill by Dr. Gabriela Soto La Vega, and it goes into a lot of that history. I'd also recommend the book Devices and Desires, A History of Contraception by Andrea Tone. And, both of these go into sort of the many facets. But another thing that I only learned within the last couple of years about the history of hormonal birth control is just how essential activism by users of the pill, former users of the pill, was to healthcare as we know it today, because many people were incensed by the side effects and the risks and the fact that their doctors didn't tell them. Certainly, if you ask many people today, disabled people, people with chronic illnesses, fat people, women, doctors don't always listen to their patients. But the culture around that was dramatically worse 50 years ago. And trust in patients was dramatically worse. And it was worse across the board, although certainly the power differentials existed as well. And activists around the issue of the birth control pill in particular got one of the very first times that there was a requirement for a patient package insert in a medication in the United States, meaning before that, companies were not required to include any information for the patients in prescription medication packages. And that first requirement was for the birth control pill. And so that's something that affects not just reproductive health, but any medication we take today. We have the option to learn more about its effects and, bring questions to your doctor. Say, wait a minute, this says that it's contraindicated for this other medication that I'm on. Did you miss that in my chart? That type of patient self-advocacy is possible, because of that movement. One of the places that is preserving this history is the Dittrich Medical History Center at Case Western Reserve University. They have a very extensive contraception collection, not preserving the physical sites, but preserving the material culture. So the contraceptive devices themselves, as well as the packaging. And this is a second answer to your question, but I also wanted to mention that I think there's some great work being done, but opportunities for so much more could be done around looking at the history of why people avoid mainstream medicine, because there's a number of historic sites that are preserving quote unquote alternative medicine histories, whether they're absolute quacks, whether they're people who are really providing healthcare but are not trained doctors. Maybe they're trained in something else. Maybe they're midwives. Those stories they exist, but they're not sort of integrated into people looking for healthcare history, wouldn't necessarily find them. And I think that that's so important to understanding today why people resist mainstream medicine. Sometimes they have very good reasons, but mainstream medicine saves lives. And so integrating people's concerns about mainstream medicine, and it's not just stubbornness, there are many valid, cultural reasons, ways in which mainstream medicine has oppressed people, ways in which it has been dangerous that need to be addressed. And I'm sorry, this is a topic I could speak on for an hour, so I'll stop there. But
I assume while you're researching your book, in your day-to-day work, that there had to be some real standouts for you between healthcare of the past and healthcare present. So what was the most glaring difference, or maybe the most obvious similarity of something that hasn't changed in 100 years?
So honestly, I think that medicine is an area where it is especially difficult to draw a distinction between past and present. So my book does go up through the present. The most recent artifact in it is a Narcan injector from a couple years ago. I also mention September 11th, 2001, and a couple of other more recent topics. And I can't find one standout thing. Certainly germ theory changed a lot, anesthesia changed a lot, but I think pertinent to kind of power and justice in particular, over the course of the 20th and early 21st centuries, there has been a lot of progress in patient rights, study subject rights, and consumer rights as related to health. Early 20th century, you saw the beginnings of the FDA and the first regulation in that regard. Kind of episodically throughout the 20th century, there was legislation that affected study subject rights for the first time. And then patient rights in things like the right to be informed, what consent looks like, what informed consent looks like, changed dramatically over the course of the 20th century. And then in the past 20 years, we've seen expanded access to healthcare and more people recognizing that healthcare is very expensive in America. And I want to call out that series of transformations as being linked to one another. I believe they're very positive transformations, but they're also not inevitable. They have been the result of hard work by activists, by people in these fields, by patients themselves. And so while right now it looks like a trajectory of progress, there are many cases in which rights related to healthcare are being systematically stripped away. And so that ties back to the idea that this is all a continuum. There isn't a break between past and present.
My mind's just going to melt with all my additional reading I have to do after this. But activism, I mean, that's really what we're trying to weave through our story today. So Kamal, as the lawyer in the group, in what ways do you think cultural heritage practitioners could or should consider using their research to assist with present day legal battles? For example, there's historians who provide expert testimony for tribal water and land rights, which we know ties into mental and physical health as well. So let's say we have any experts in our audience. What can they do to offer their expert testimony, or are there other opportunities for people to use this research on a legal platform?
That's a really excellent question. I think that, I think being an advocate, as a public citizen for the retention of archives, for the repatriation of archival materials is very important. And that's certainly something that lawyers can assist with, either in their capacity as attorneys or as advocates. Last year was a big controversy about the Seattle archives that were going to be moved. And I think the buildings were going to be sold, but contained in those archives are thousands of documents related to tribal treaties, fishing rights. There were immigration documents that were at the Seattle branch of the National Archives. All of that could have been potentially lost. And so, there was the AG, the Washington AG got involved, and there was a back and forth between the Trump administration, and when the Biden administration came in, he ultimately canceled that sale of the building, and the archives would not be physically moved. So, on a local level, helping to make sure that archives stay where they are because of their importance to communities. And then also, like I said earlier about, if you know that there are pieces of someone's archival history that were missing or that were stolen or are being somehow misused, lawyers can advocate for the return and the proper use of those documents, because they're so critical to our understanding of people's oppression, but also for a particular community, for their well-being. So when you look at what happened in the residential schools and the Native American boarding schools, we mentioned physical and mental well-being. Those children's physical and mental well-being was adversely impacted by what went on there. But without access to those kind of archival materials, or if those things were translocated and things were lost, the descendants won't necessarily have access to try to maybe find out where their ancestors' remains were, so that they can get a dignified burial, or so that artifacts that are important to them that could be returned. So as it relates to build heritage, it's important for there to be archival access, so that we can know the proper context for a building. And so because attorneys work with all types of records, them assisting in those types of projects, is definitely critical.
And I think you really hit on a complicated point, but an important point. Oral histories are difficult to put into a court case because those aren't hard data as it's perceived legally. So you reinforcing the importance of archives and access to archives is really important for us all to recognize when we're lobbying and advocating for legal rights of all. People want the hard archival primary sources compared to how we now are shifting for history to be more inclusive of oral histories and stories that are passed multi-generationally. So Gillian, I really appreciate how seamlessly you intersect religion, sexuality, and healthcare. And there's a great vintage graphic on your website that says, "Is the schoolhouse the proper place to teach raw sex?" Which seems to be something on headlines today still. So we work at institutions and historic sites that have board members who are fearful of broaching conversations tied to sexuality. What are some suggestions to help destigmatize these conversations and reinforce that this is tied to health history and, it's not a house divided? Any suggestions for people who are getting that sexuality pushback for telling the full story?
Sure. So I should probably clarify what that image is and where it comes from first. I wish I had brought it to put up on the screen. So that comes from a group called MOTOR-READ, which was associated with the John Birch Society. MOTOR-READ stands for Movement to Restore Decency. They were focused, and you'll get where I'm going with this in a second, on countering sex education initiatives in schools starting in the early 60s. Their working theory was the mere talk about sex or sex education, no matter how banal, and associated with Christian Crusade as well. So would somehow incite children to become sexual and pervert their sexuality. Any sexual education outside the particular kind of church and a particular kind of home they believed was detrimental. And so their imagined opponents were groups like radical groups like the PTA, or just local church groups that were liberal and wanted to have sex education. So their idea was that any sex talk was inflammatory and dangerous if it was done in the school and outside the home. So how do we talk about sex in the sort of historical vein and in public spaces? My rule of thumb is always to be frank, candid, non-sensational, and direct. I think that we always have to ask, when telling a story that involves sexuality, how does discussing sexuality further that story? For me, when we discuss it, it's always within a matrix of power relationships and in service of a broader narrative. I always advise my students, and when I advise people on how to do oral history, being direct, being candid, not being lascivious, not being gratuitous is the way to go. And you can tell any story that way. In our podcast, we've told the story of phone sex operators. Now, granted, we have a little bit of fun. We show the recordings that they did. Some of these are very graphic, but it's always in service of a larger story. Now, we are not shoving a museum or a display or a history in anyone's face. People can opt in. And we can also say, and caution them and say, as I do with my students, this class will be discussing graphic matters. But our job is not to explain away or hide. It's to invite people into the social worlds in which sex was a huge part. And if we remind folks that sex saturates our society in the past, in the present, and giving them a means to interrogate that critically, I think we're doing that a responsible intellectual task. So that's where I would begin. And just to really encapsulate that, inviting people to ask questions about what they're seeing, giving them a mode to engage with it, giving them fair warning that they might see something that might discomfort them, and then we go from there. But I also want to flag one thing. When people become discomforted around sexuality, it's often around certain kinds of sexual expressions, and whether it's graphic kinds or things that are not normative for them. Because I want to emphasize again, sexuality is everywhere in our culture, and it's everywhere represented already, often in the stories we tell in public spaces. But for many people, an image of a couple or certain kinds of courtship is totally quotidian. When it goes against the grain of what they're used to, that is when they become, again, agitated. And I'll give a classic example, which we might not think of. Thinking about the sort of end of World War II, we have often seen the picture of the soldier kissing that woman in, I believe it's Times Square. Someone can fact check me on that or qualify it. We later learned, but by that I mean recently, that that was a non-consensual image, which completely recast our non-consensual act, how we might interpret it. I was recently at Grounds for Sculpture near Princeton, New Jersey, where they had, for the longest time, a life-sized 40-foot tall statue of that particular image. It was so iconic, right? Gets a very different spin on it. So how do we tell that story? That story which embedded in iconography of American triumphalism, the good times starting again, the glorious post-war period, is an image of a non-consensual act. How do we tell that story? And so I think we can do it frankly and candidly. But I raise that image to show that it, A, is ubiquitous, and B, when we dig a little deeper, that image can be very unsettling.
Oh, thank you. I know we're running a little long because I got excited with questions. So as you all think of your closing thought, I'm just going to read out a couple comments. We didn't have questions, we just had comments, which is great. Jason said, my family is from Central America, and many of the older members have a distrust for doctors here in the US. Ironically, they trust doctors back home and sometimes travel to Central America for checkups. It's definitely a culture thing. We also have a comment just saying, great question for those of us balancing legal aspects. Really appreciate this discussion and look forward to sharing it widely. So we have some enthusiastic attendees and you're giving them food for thought. So what's the final food for thought? Anyone can start. Tegan?
Sure. I guess if people take away one thing from today, I would like it to be that history of health is and must be intersectional in the sense that Kimberly Williams Crenshaw coined it, to mean that not just social identities overlap, but that the fact that they overlap itself creates power structures. The experience of a white woman and the experience of a Black woman and the experience of a Black man are all going to be different in different ways from the experience of someone who has, the societal privilege of a white man. And that is fundamental to understanding the history of healthcare in the United States and probably everywhere. But power and privilege and how those are used as tools. It isn't a lens through which to view medical history. It's fundamental to medical history.
Thank you. Kamal?
Sure. So I just have one quick clarification. Thanks to Gil. It wasn't Governor Brown that went after Inez Burns. It was when he was the district attorney. So thank you for that, Gil. And I just wanted to say that, looking at the stakeholders and how everyone is a part and shares in social space, we need to kind of interrogate how those social spaces were created, particularly as it relates to medicine, which, as everyone said, has been a place where vulnerable people have been oppressed. So looking at how we got to where we are now, and where we were in the past, requires the use of archives, requires incorporating oral histories. All of those things are necessary to interrogate the kind of social structures that form medicine and medical history.
Gillian?
Sure. I'm going to just flag the moment that we're in for a second, which is we are seeing a radical restructuring of reproductive health care right now. But more bluntly, we're seeing a real, with the Dobbs decision, erosion of access to healthcare and a shifting in how abortion provision and healthcare provision around reproductive rights is going to be done in this country, which is to say, for those of us who are in the field of collecting documents, preserving documents, and making sure there is a record, now's the time to pay attention as things on the ground are shifting rapidly. So capturing the stories of the frontline healthcare providers, the abortion seekers, the legislative debates is really essential work so that we can have a vital record of this change over time.
We want proactive preservation and conservation. We want to use what our work to empower, and we want to not repeat history. Hopefully we can avoid going back too far in the past. Thank you again, all of you, for this conversation. I really appreciate you taking the time, and I'm going to sign